In the middle once. Okay.
Okay. So this is a saying by unknown person that there are two types of people in the world: those who love infectious diseases and those that don't know about infectious diseases. Because if you know infectious diseases, you just cannot stop loving it. And as William Osler had rightly said, the humanity has three great enemies: the fever, the famine, and war. And of these, by far, the most terrible and greatest is the fever. So we need to know everything about the infectious diseases. And this is the main point which I want to focus today, is that fever is not a sign of ceftriaxone deficiency. What happens, you should know what is happening in the real world right now, because whenever a patient comes to you with a fever, you give some medicines, he comes back on the second day, he's not responding to the whatever the treatment you are given. All the majority of the doctors, the specialists, the non-specialists, all kinds of people, what they're doing is they're admitting the patient and they're just putting on the so-called antibiotic, that is ceftriaxone, and they just wait for the fever to subside. So in 90 out of 100 patients, the fever is going to subside because it is either a viral fever, it is anyhow going to subside in the next 48 hours. But in the next 10 patients, the fever is not going to subside, and the treating doctor does not have any clue. By the time the patient might have developed the organ damagement, or the patient has gone into sepsis. So all these kinds of the mismanagement is been occurring in the real world. That is just because we are not focused on the right diagnosis. Because if you don't have a right diagnosis, you just cannot consider a management. How can you just hit a blind spot? So if a patient is having a fever, always try to get a diagnosis before actually treating the patient. So that's why, as I told you, and I have been repeating, that antibiotic stewardship is being a very, very important in the day-to-day practice. So the first case which I have taken today was a 32-year-old male patient who came from rural Karnataka and who actually presented to our casualty with complaints of fever, severe malaise, and polyarthralgia since 8 days. And he was shown to the local practitioner on OPD basis 3 times since last week. So he went to the same local practitioner for the 3 times in the last week. So the same complaints. Patient had severe malaise, and he received a treatment in the form of some tablets and IV fluids. The patient each day used to go to the local practitioner. He used to give him some IV fluids and some tablets. So the tablets received basically was the combination of cefixime plus ofloxacin and some Dolo 650 and some supportive management, the pantoprazole, all these kind of things. So when he presented to our casualty, his pulse rate was 55, his BP is 110/70, his respiratory rate is 20, his temperature is 101 degree Fahrenheit, his SpO2 being normal. The patient was having severe prostration, that means severe sweating, and the dehydration was present. And the systemic examination was actually unremarkable, and there was no organomegaly for abdominal examination. This was actually noted from our duty doctor, and the patient had already got these reports from the outside, from that local practitioner. His hemoglobin was 12, his total leukocyte count was 4,600, his platelet is 1.8 lakh, his ESR is 43, a little bit higher, the urea and creatinine is normal, and his CRP is slightly increased. So this patient came to the emergency, and my duty doctor received the patient and checked these reports, and he himself, before informing me, got these investigation that he got his viral done to rule out the enteric fever. It was negative, and the dengue serology was negative. The malaria, the kit method was negative. The wheel Felix was negative. The HIV was negative, and the VDRL was negative. So these were the routine investigation he got done by his own knowledge. So then after he informed me the vitals and the patient reports. So if you see this patient, what is the first thing you notice here is the fever is since 1 week, that is an acute fever. And you see this pulse rate. This is 55. The patient is going into bradycardia, and the temperature is 101 degree Fahrenheit. So these are the very, very important things which you should focus. Whenever you enter the field of medicine, I think 90% of the deal is with the vitals. If you know what are the abnormalities in the vitals and what can cause these vitals abnormalities, the half of the treatment is actually over. So this patient was actually, since he had bradycardia, I advised his ECG, and ECG showed this. So if you see this actually ECG, what is it, heart rate? The heart rate is being pretty low. It is around 40, 45. And you see the PR interval, it is definitely prolonged. See the PR interval? It is more than 120 milliseconds here. So this is a first degree heart block. So your patient has come with a fever and first degree heart block. So can anybody give some differential diagnosis to the, what you call, the possibilities here? I think if the interested candidate can go ahead with the answers. If at all, I'll just go on discussing these things. Okay, so the working diagnosis in this particular case becomes the fever with bradycardia. So what are the causes of fever when you see a patient with bradycardia? There can be a relative bradycardia and there can be an absolute bradycardia. Please understand this particular terminology. It is relative bradycardia. It is not an absolute bradycardia. I think I have repeated it in my case discussion thing also. The relative bradycardia is the dissociation between the temperature and the pulse rate or the heart rate. So there is a definite association between this temperature and pulse rate. That means every 1 degree rise in temperature increases the pulse by 10. This is a definite association. If there is a dissociation between this association, then it is called the relative bradycardia. That means for every 1 degree Celsius of increase in the temperature, the pulse rate has not increased by 10. Then only it is called relative bradycardia. Relative bradycardia patient need not have the actual bradycardia. For example, as I told you, if the patient is having 102 degree Fahrenheit of its body temperature and his basic heart rate was 80, so his temperature had increased by 2 degree Fahrenheit approximately. So the pulse rate should have been 100 in this particular case. So if this patient has 90, then it becomes the relative bradycardia. This is what is a relative bradycardia. So relative bradycardia is definitely different from the absolute bradycardia. Here, our patient has the absolute bradycardia. So don't consider this patient for the relative bradycardia here. So again, for the sake of the completion, you all know the causes of relative bradycardia. The terminology is a very, very important thing in case of the internal medicine discussion. Any case discussion, whenever there is a discussion regarding the fever, this question is definitely going to come, whoever is the examiner, whoever the student is. So for the relative bradycardia aspect, we know there are some infectious causes and some non-infectious causes. So non-infectious causes of fever, which can have the relative bradycardia, is the patient who is having drug-induced fever or drug fever. Here, the temperature and the pulse rate association is not appropriate. Then if the patient has factitious fever, self-induced fever or malingering, or if the patient is having some CNS lesion, for example, if the patient has CNS lymphoma, lymphoma can have fever, and due to this lymphoma, there is an increased intracranial tension. We know this increased intracranial tension can cause Cushing's reflex, which can increase the blood pressure and decrease the heart rate. So this Cushing's reflex can induce some amount of bradycardia in this patient of lymphoma. So any case of CNS involvement, for example, in case of meningitis, encephalitis, if there is a raised intracranial tension, they can also can be the considered for the cause of relative bradycardia. Whenever I see the students answering enteric fever as the first thing when they ask what is the cause of the relative bradycardia, enteric fever is a very rare cause of relative bradycardia. Till now, I have not seen an enteric fever which is presenting in relative bradycardia to be factious. So if you know the infectious causes of the relative bradycardia here, as I told you, any viral fever can cause the relative bradycardia here, and all the intracellular bacteria, like all these leptospirosis or this borreliosis, mycoplasma, the chlamydia, the syphilis. All these can cause the rickettsia. All these are intracellular bacteria, so which can cause the relative bradycardia. And one extracellular bacteria is everybody's favorite, that is enteric fever. So for today's, in our case, the patient presented with a heart rate of 50 with a first degree of AV heart block. Definitely, this is not a relative bradycardia. So here we are dealing with the absolute bradycardia. So if you actually encounter the absolute bradycardia in your patient, what are the possibilities you usually expect? So this can be an endocarditis, because the infective endocarditis can have the involvement of the conduction system, can affect the heart rate, and can also cause the first degree AV block. This can also occur in the acute rheumatic fever. The heart blocks are also common in case of the acute rheumatic fever, although rare, but is possible definitely with the fever with bradycardia in picture. Then Lyme's disease is a very common cause of the carditis, where the fever and the cardiac involvement is common. Chagas disease, the trypanosomiasis also is common, but it is not definitely seen in India. I have not seen a case of Chagas disease in my life. Syphilis carditis is also possible in causing bradycardia. The tuberculosis, again, causing the myocardial involvement or the pericardial involvement, can also cause the bradycardia, although it is very rare, can be considered in a patient who is having a chronic issues. Here our patient has the acute issues. And diphtheric myocarditis is also very, very common. But here definitely the patient progress from the upper respiratory tract involvement. Like the patient has the severe sore throat, the white patches, the bull's neck, all these, then progressing to involve the myocarditis is very, very common. And toxoplasmosis is to be suspected in a case of the immunodeficiency. Although in recently the COVID-19 has been attributed to cause the bradycardia in case of fever, the dengue is being reported in causing bradycardia, although again, it is due to involvement of the myocardium directly causing myocarditis. So if at all you are seeing any cardiac abnormalities, inherent cardiac abnormalities in your patient with the fever, so you need to suspect the involvement of the cardium directly rather than the indirect elicitation of this bradycardia. So here, to rule out this, the infective endocarditis was ruled out with the echo in our patient. The acute rheumatic fever was ruled out due to the patient was not fitting the Jones criteria, and the Chagas disease was not possible. Syphilis was ruled out due to VDRL negativity. Diphtheria, the patient did not have any features suggestive of it. The toxoplasmosis was not possible with HIV being negative here. So we tried to rule out the Lyme's disease in the patient. So his ELISA for Lyme's disease came as positive. So we confirmed this patient with the IgM Western blot, so which came as highly positive in our patient. So this Lyme's disease is a very, very important thing for the people who are especially preparing for the USMLE and the lab exams, all these things, because this is a very common infection in case of USA and European countries. Although this is not so much rare in India, it is slightly lesser common compared to the other routine causes of the fever. So Lyme's disease is actually the infection which is acquired due to the bite of the ticks, that is the specific ticks that is called as the exorted ticks, who are infected with this typical organism called the Borrelia. So this is actually a spirochetal infection caused by the bite of the infected ticks, that is exorted ticks, which are infected with this bacteria, that is the borreliosis. So these exorted ticks are what you call the entirely distributed all around the world, being very common in all these forest kind of areas and the rural areas and all the animal husbandries. All these things are exclusively filled with this exorted ticks, even in India and South India also. So this exorted ticks has got the 3 stages, that is a lymph larva stage, which grown to the nymph stage. The nymph stage also grows into the adult male stage. So these acquire this bacteria by biting through the other organisms. That is basically the mice is the basic reservoir of this Borrelia organisms. So these mice who are infected with this Borrelia organisms may not be having any disease. They may be completely normal. So these ticks are dependent for their survival on the other organisms by their sucking in the blood. So they usually suck on the mice, especially these larvae and the nymph. They usually are situated on the surface of this mice and other organisms like deer also, so which sucks the blood. So while sucking the blood, the organism which is there in the blood also enters into the tick. So when this tick bites into the humans, so these humans can have the infection transmitted by the Borrelia organisms. So this is a very common infection in case of the people who are situated in forest areas, people who commonly visit the forest areas, the farmers, all these things, especially in case of the early summer and the spring areas. So the Borrelia organism, there are many subtypes in the organism, but the very commonly encountered organism is the Borrelia Burgdorferi. You might have studied in the microbiology section. There is other organisms called Borrelia afghani. And there are many other organisms like Garini, all these things. But Borrelia Burgdorferi is the very common organism which has been implicated in causing the Lyme's disease. So after the bite of this tick, some of the people may remain asymptomatic due to their working immune system. Some of the patient may develop the actual symptoms. So this Lyme's disease is usually divided into the early disease and the late disease. And the early disease is divided into early localized disease and early disseminated disease. So in some patients, this early infection after the bite of the infected tick may remain localized to the site of bite. Whereas in some patients, it might disseminate involving the multiple organs systems. So what happens in the early localized infection? So after the bite of the tick, that area becomes red and the hot and swollen. So this becomes initially develops into the macule and papule, then develops into a distinct lesion that is being very specifically attributed to the Lyme's disease caused by the tick bite, that is called as erythema migrans. So whatever the area of tick bite is there, macular papule is developed in the original site of bite, go on spreading to the surrounding areas, and then the clearing from the center starts. So there appears a central area of clearing followed by a area which is spreading. So this lesion can become such a big thing, like it can become up to 20 centimeter, 40 centimeter big. So, and the central lesion may also develop the vesicles. So this is possible. If you see erythema migrans once in your lifetime, you will never forget. Although in our particular patient, he did not have any history of tick bite, erythema migrans was not seen in the patient. This has been true in case of 30 to 40% of patients where they don't remember the bite of tick, or they don't have the erythema migrans in their early period. So this erythema migrans, the central lesion may become vesiculous, but what is very peculiar about this erythema migrans is it never undergo necrosis. Whereas if you see a bite of a mite, there is a central eschar, all these become centrally necrotic and eschar might come out. Whereas this erythema migrans either disappears or it peculiarly spreads to the entire body, but it never go into a necrosis. So central area starts clearing and it goes on spreading from the surrounding areas. So along with this early localized infection may have the constitutional symptoms like the fever, headache, and some signs of aseptic meningitis like the neck stiffness, vomiting. And although the abdominal and the respiratory features are very rare, in fact, if you see a predominant respiratory features in case of this early fever or early febrile illness, the Lyme's disease is usually not possible. Whereas some patients in the early disease may get to involve the disseminated features. So these disseminated features can involve the CNS or the cardiac system or the ocular system or the skin. So this early disseminated disease in the CNS involvement has been very common. There are some peculiar features about this CNS involvement in the Lyme's. So these are all possible in case of the early disseminated Lyme's disease, that is lymphocytic meningitis, and the unilateral or bilateral facial nerve palsy, and the typical painful radiculopathy that is called as Banwarth syndrome is also been reported in case of the Lyme's disease. The peripheral neuropathy is common. The mononeuritis multiplex, although rare possibilities of cerebellar ataxia and encephalomyelitis is being possible. So if you see actually here, any level of the central nervous system involvement can occur in case of Lyme's disease. So whenever the patient has the multifocal involvement of the CNS with acute febrile illness being the history, the Lyme's disease should be the consideration. So one of the very peculiar feature which you should remember here is the one of the cause for this bilateral facial nerve palsy is the Lyme's disease. Although in medicine or in neurology, there are very rare causes of this bilateral facial nerve palsy, the Lyme's disease is one of the things. So if you actually want to know other causes are the sarcoidosis and tuberculosis, and very rarely systemic sclerosis, multiple sclerosis. So these are the common causes of the bilateral facial nerve palsy. Otherwise, in all the other conditions, the unilateral facial nerve palsy is usually seen. Whenever you see a patient of bilateral facial nerve palsy, in the background of the acute fever, you need to suspect the Lyme's disease. In the background of the chronic PUO or other multi-system involvement, you need to suspect either sarcoidosis or tuberculosis. All these things you should remember. Although any cranial nerve involvement can occur in this of Lyme's disease, the facial nerve is the very common cranial nerve involved, although next common is the abducens nerve. We might have studied this famous triad of the neurological Lyme's disease, that is meningitis, the cranial neuropathy, and the radiculopathy. That means you have the involvement of this brain meninges, the cranial nerves in the brain stem, and the radicular tract, which can have the multifocal involvement at the same point of time in the patient. Although this is very rare in nowadays because of the proper treatment. So next system which gets involved is the cardiac system. The cardiac system can have the varying modes of presentation. The usual presentation is by causing the heart blocks. The heart blocks, one of the very peculiar feature of this heart blocks in the patient of Lyme's disease is a changing heart block. You see today the patient is having first degree heart block. Within some time, progress into the complete heart block, and again comes back to the normal sinus rhythm, and again changing from the first degree to second degree, then Venki back. All these exchange between the rhythms is very common in case of Lyme's disease. So this can occur even in seconds in case of Lyme's disease. There have been case reports of changing rhythm within seconds. First degree heart block is suddenly progressing into the Venki back, then progressing into high degree AV block. The CHB is also been possible. Although since this is a infectious disease with a proper infection, this is going to be right with the right treatment. Other way of the presentation of this cardiac system is the myopericarditis. Although chronic heart failure is also being reported in case of Lyme's disease, but the most common abnormalities which we usually see is the conduction abnormalities causing the bradyarrhythmias. And the next, the ocular involvement is also very common in case of early disseminated disease, where it can cause the conjunctivitis, the keratitis. There's a mixture of both, that is keratoconjunctivitis, the corneal scars. All these are possible in case of Lyme's disease when it spreads in the entire body. The skin involvement is also occur in case of the disseminated Lyme's disease in the early point of time. There are the two types of the cutaneous involvements are very common in case of the early disseminated disease. One is the multiple erythema migrans. So if you see a patient having multiple erythema migrans, you should not suspect multiple tick bites. You should suspect disseminated Lyme's. This is again an entrance question from the AIIMS. The multiple erythema migrans suggests what? Multiple erythema migrans, I think options where the multiple bites, the disseminated infection, the cardiac involvement, and the vasculitis. All these were the options, and the right option is the early disseminated disease. So it is not a sign of multiple tick bites. Again, this is where the trick in the entrance exam, which you should know. And other feature of this early disseminated disease in case of the cutaneous involvement is the Borrelia lymphocytoma. As the localized violaceous lesion may appear on the site of skin bite, which might outgrow the skin to form a definite lesion, which if you do the biopsy may have a lymphocytic infiltration. Sometimes they may progress into the primary lymphoma at that particular site. Also, this is very not common in nowadays, but it has been definitely reported in the literature. So in case of the Lyme's disease, we have an early disease and we have a late disease. In case of an early disease, our patient can have an early localized infection, which is having erythema migrans with the constitutional symptoms, or early disseminated disease where it can have a CNS involvement, the cardiac involvement, the ocular involvement, and the cutaneous involvement. And again, to repeat here, the multiple erythema migrans is not a feature of multiple tick bites. Multiple erythema migrans is a feature of disseminated infection. And one of the common cause of this bilateral facial nerve palsy in the background of acute febrile illness is a Lyme's disease. You should know. So if you actually want to know the chronic infection of this Lyme's disease, one of the very common peculiar dermatological condition is being reported that is being called as Acro Dermatitis Tropicans chronica. So this is a very chronic feature of this Lyme's infection where there is an acro dermatitis. We know that acral means the foot and the hand, that is the extremities. So there is atrophica, that means the atrophy of the skin. There is some amount of dermatitis. With the atrophy, the skin becomes very thin and the underlying loss of the subcutaneous tissue, the loss of the skin folds, the skin becomes very fragile, and this is a chronic condition. So the acro dermatitis chronica atropicans is a feature of chronic Lyme disease. This is also very, very common. I think n number of multiple entrance questions are being possible with this Lyme's disease. So to diagnose this Lyme's disease, if you have erythema migrans, you need not have any other supportive evidence. Please remember this. If you see a typical erythema migrans, no other serological test is being required in the patient. It is definitely the Lyme's disease. And another reason why they don't offer a serological test in case of erythema migrans is since erythema migrans is a localized disease, the patients may not have or may not develop the systemic antibodies. So the ELISA and all the serological tests may actually come negative. And another reason is since the erythema migrans is a very early feature, since there is a time to develop these antibodies, so the antibodies or the serology may come negative in this early period when the patient has erythema migrans. So if you see erythema migrans in the background of acute fever, you need to straight away consider the treatment of Lyme's disease and offer them the right antibiotics. Yes, if erythema migrans is not there, if it is not present, as in our case, the first, there is a two-tier system has been advocated to the diagnosis. First is you need to get the ELISA test. So if you have a negative ELISA, then the Lyme's disease is definitely ruled out. The specificity is very high here. Sorry, sensitivity is very high here in ruling out the disease. So ELISA has got a very high sensitivity. If you have a negative ELISA, then it is definitely not negative, definitely not Lyme's disease. Yes, if the ELISA is positive, then it can still be Lyme's and it still can be other infections. So to confirm the Lyme's disease, we usually offer the Western blot test for the IgM or IgG antibodies. So the positive immunoblot test is the confirmatory test or the highly specific test for the Lyme's disease. So the highly sensitive test to rule out the disease is the ELISA, and highly specific test to rule in the disease is the Western blot. So in our case, initially the ELISA was done and it came positive, and then we also confirmed with the immunoblot test to have IgM positivity. Why this is important? Because the treatment duration is very, very important in case of Lyme's disease. The early stoppage of this treatment can have the recurrence and can also progress into chronic Lyme's disease, where the patient might develop some cutaneous conditions, as I told you, and also develop this chronic neurological issues, like patient can have the chronic neuropathies, multiple mononeuritis, and the radiculopathies are also very, very common, which becomes very, very difficult to treat in a later point of time. So if you actually see this treatment summary of this Lyme's disease, the antibiotic of choice in case of the erythema migrans and non-focal symptoms is the doxycycline. So the first, second, and third choice of antibiotic in case of Lyme's disease is the doxycycline. And remember, the duration of regimen is 21 days. The minimum of 21 days doxycycline is required for this Lyme's disease. You can give either oral or intravenously in this patient. So the next alternatives are the amoxicillin or the azithromycin, where you can consider these patients if the patient is having less than 8 years, or if the patient is pregnant, or if the patient is not tolerating doxycycline, although doxycycline remains the first line of treatment. Whereas if the patient is unstable, or if he is having serious organ involvement, like he is having the central nervous system involvement or the Lyme carditis, then the ceftriaxone comes into the picture. It is the ceftriaxone enhanced dose, that is the meningitic dose should be used here. What is the meningitic dose of the ceftriaxone? It is 2 grams per day, or the 2 gram IV is the dose. It is not 1 gram BD, it is 2 gram IV. And similarly, it is with the carditis involvement, the ceftriaxone comes into the picture. So this should be given in the intravenous route. The oral route does not have any benefit as far as the carditis or the central nervous system in case of Lyme's disease involvement. It is only IV which has been approved. And again, the doxy can be given either oral or intravenous dose, whereas ceftriaxone should be considered with the IV, especially if the patient is having the hemodynamic instability in the background of Lyme's carditis. And if the patient is presenting with a chronic disease, then the duration can still be increased to 28 days, that is 1 month duration of the either doxycycline or amoxicillin or ceftriaxone. So if you look at the dose here, the doxycycline, the drug of choice here, we know that the American Society of Pediatrics allows the usage of doxycycline less than 8 years. But some people do consider that doxycycline should not be used below 12 years. So in age above 12 years, it should be used as 100 mg BD 21 days. The short courses, short and the large dose courses are also available, where the patient has given 200 mg twice a day or 400 mg daily for the shorter duration. But the most used regimen is 200 mg per day in divided doses for 21 days. In children, remember, we usually don't ask the dose of doxycycline in case of children. Whereas if the Lyme's disease is the diagnosis, then you can use the 5 mg per kg in 2 divided doses in children. Please see the advertisement here, that is the doxycycline and azithromycin have no marketed authorization in all of the countries under the 12 years. Even in India, I have seen many doctors putting doxycycline 100 mg tablet, sometimes 50 mg BD, whatever the way they want. Ideally, they should not be used in the children less than 2 years. However, in a specialist practice, less than 9 years, it can be used under the observation. But again, the full responsibility comes by the prescriber, that is the physician or the pediatrician. So with the ceftriaxone, if you are using, it is 2 grams 2 times daily, that is totally 4 grams. So this is the meningitic dose which is being approved in case of Lyme's disease. It is not again the 1 gram BD. So you need to remember this right dose and right duration in case of Lyme's disease treatment here. I think this is very, very important to understand the concept of the relative bradycardia and the absolute bradycardia, and what all to suspect. Whenever you see a patient of febrile illness with the cardiac involvement, being at an extreme tachycardia or being at an extreme bradycardia, you see. This is very common if you actually sit in emergency. Many of the patients are shooting their pulse rate into 150, 160 in the background of fever, where if you actually record their temperature, it may still be 901, 102. So with this slight rise in temperature, the pulse rate should be expected around 110, 120. But if you actually see, they might have 140, 150. So whenever you have an unexplained tachycardia in these patients, you need to suspect the underlying the abnormalities also. The patient can have myocarditis. Again, the patient can have pneumothorax, patient can have pleural effusion, the patient can have the sepsis, the patient has gone into acute myocardial infarction. So all these cardiac abnormalities and the myocarditis involvement in the Kawasaki disease, all these are very, very important causes of the extreme tachycardia in case of the fever. So we should know all the extremes here. So to go to the second case here, here it is a young 28-year-old male patient who came with fever since 1 week. Fever since 1 week. It was high grade with chills, and it is continuous fever. He had a severe headache. He had a prostration and malaise. So patient here had a history of travel to the Coorg for trip with friends 15 days back, and with the fever onset just after returning from 4 days of trip. So just after returning from the 4 days of trip to the Coorg, he developed fever. And this fever, he presented to me with a history of 1 week, which is very high grade. And he had chills. Continuous. Patient was having severe headache and prostration and malaise. And patient had received this cefixime and ofloxacin combination. I think this is a very irrational combination where the people still now using. The cefixime with ofloxacin combination is an irrational combination. I think many of the companies have withdrawn this particular preparation. Still, it is available in some areas. So he had this particular tablet for 5 days with no response. Then he was referred to our hospital. His pulse rate was 84 at the time of the admission. His blood pressure was little low, that is 100/60. His respiratory rate was 18. His temperature is 103 degree Fahrenheit. It is high. See, again, if it is temperature 103, the pulse rate should have been around 190 or 110. Again, it is not that level. So here you can tell this patient is having the relative bradycardia. So this is ideal candidate for the relative bradycardia. And his saturation was 96. And on per abdominal examination, he had a mild non-tender splenomegaly, and he had also a mild tender hepatomegaly. So this patient got done the routine test. He had the mild anemia, that is 11.2. He had the leukopenia, that is 3,400. His platelets were low. He had 87,000 of platelets. His urea creatinine was normal. He had normal total bilirubin and the direct bilirubin. He had raised liver enzymes of 3 to 4 times. The SGOT was 108 and PT was 96. His alkaline phosphatase was normal. CRP was increased, and his ESR, the non-specific markers of the inflammation, was increased. So the Vidal was 1:80. The dengue serology, the IgG was slightly positive, and malaria was negative. So for this particular report, the patient was sent to our hospital, stating that it is a dengue. So here it is an IgG positive. Please remember this IgG. IgG is everybody of us know it is a sign of past infection. So again, this is a very common mistake in the routine practice, that IgG is being managed. IgG positivity is being managed as a dengue fever. Again, 90% of the times the patient is going to improve by their own. Where they know they don't need an actual diagnosis. Sometimes patient might progress into the multi-organ dysfunction, where you are just sitting with a diagnosis of dengue in your hand, where it is actually, it might be malaria, it might be the leptospirosis, it may be rickettsia, anything is possible. So this patient, the working diagnosis we kept was the acute febrile illness with the thrombocytopenia with the transaminitis. So if you see these 3 components, anything can be possible. If you see the commonly, again, dengue can have the thrombocytopenia with the transaminitis, but the NS1 and IgM were negative. This is also possible with the malaria. Again, malaria was negative in our patient, but spleen was there. And the fever pattern was not suggestive of malaria here. It was not intermittent kind of fever. It was continuous with the chills and rigors. And again, this is being possible also with the enteric fever. Secondly, the patient progressing into the second week, the spleen might appear, the patient might develop thrombocytopenia, leukopenia. The patient can have the little transaminitis with the predominant abdominal symptoms, but it all was negative. And the patient did not have any prominent abdominal symptoms in this patient. So this patient, after complete examination, he had this typical lesion. So if anybody can tell me what is this lesion is. So if you see, this is actually an eschar. If you see, so this is an eschar. This is a very pathognomonic of scrub typhus. So this patient had this typical bite. So when I went into rounds, the patient was just sitting like this. Then he was scratching in his axilla. Then I asked him to show the axilla. He had this particular very typical lesion. So this is a classical lesion of scrub typhus due to the bite of mite, infected bite, or chiggers, also called as chigger mite. So to further prove the diagnosis, we got the Wheel-Felix test done. The Wheel-Felix, the OXK was really positive, although this is not a specific or a sensitive. We just confirmed this particular test by the indirect immunofluorescence, where the antigen for the scrub typhus came positive. So scrub typhus is a mite-borne infectious disease. Is actually caused by this organism that is called Orienta succidomici. So earlier this was included in the family of rickettsial bacteria, but this is not. They have discovered that this belongs to the different genus, and again it is a gram-negative Coccobacillus, and it is genetically distinct from the typhus group of Rickettsia. All this typhus fever causing the endemic fever, epidemic fever, although have some similarities with this organism causing scrub typhus, whereas it is genetically distinct from the original Rickettsia. And this organism is distributed throughout the Asia-Pacific rim, and disease has been endemic in Korea, China, Taiwan, Japan, India, and Pakistan, Bangladesh. All these tropical countries are heavily infected with these organisms. And again, here the diagnosis is often unconfirmed because patient usually overlook, the doctors are overlooked and some confused with other endemic febrile illness. As I told you, whenever they see the thrombocytopenia picture in the background with the IgG positivity, or sometimes even if dengue is negative, they still consider dengue as the possibility. So this is wrong practice to do. So this infection is a very, very common infection in case of farmers. And this infection is also very common during the times of summer and early spring. And there is some amount of geographical clustering is seen with this organism due to the predisposition or due to the preferential towards the particular geographical areas due to the benefits in their survival. So these are the chigger mites are implicated in causing the scrub typhus. So this scrub typhus usually begins with this constitutional symptoms of headache, malaise, and sometimes abrupt onset of fever. And as the illness evolves, the patient can develop the following symptoms. Sometimes the fever, which typically lasts longer in untreated patients. If you actually don't treat this patient, the fever is not going to subside. Unlike in case of dengue and other viral illnesses, even if you don't do anything, majority of the patients are going to recover by their own. Whereas if it is a scrub typhus, the fever is not going to subside with the improper treatment. And intense generalized headache. I think this was told to me by my consultant physician. If you are especially seeing the intractable headache during the onset of very high fever, you need to suspect the rickettsial infection or specifically the scrub typhus. So this is what made me to look for this eschar and to order for the specific test for the scrub typhus in this particular patient. So that's why you need to learn a lot from just watching your consultants. What are the questions they're asking you in the rounds? Sometimes you may think those questions are improper or not relevant, but actually they are very, very relevant. So there is no good book other than your consultants. Just by observing your consultants, you can learn a lot. So next, the patient can have a rash. Sometimes they have a non-pruritic maculopapular rash. That rash can typically begins in the abdomen and spreads to the extremities. This has been very common in the other infections also, like dengue, chickenpox, all these things. And a very typical pathognomonic thing of this scrub typhus is the eschar. So eschar actually appears at the site of this infecting chigger bite. We know in case of Lyme's disease, the site of mite bite or the tick bite develop erythema migrans, whereas in case of the scrub typhus, the site of mite bite or the chigger bite develops an eschar. So eschar is just develops as a painless papule, and on subsequent days, the central necrosis occurs. As I told you, erythema migrans does not go under, does not develop necrosis, whereas eschar develops necrosis, and this necrosis leads to the formation of this characteristic black crust with the surrounding erythema, which has been very typically called as the eschar. So you can see the central lesion that is the necrotic and surrounding erythema. So this is a very characteristic finding of this eschar. And in majority of the patients, these are the just characteristic features. Sometimes the patient may progress to involve to the reticular activating system, where they can have a lymphadenopathy, they can have a splenomegaly, they can have a hepatomegaly. The patient sometimes can have an acute kidney injury. The patient can have nausea, vomiting, or diarrhea. The patient sometimes can have a respiratory complaints like ARDS. Again, Lyme's disease, the respiratory complaints are not that much common. Then involvement of the blood vessels, that vasculitis can also occur, and myocarditis is also being reported in case of this scrub typhus. So if you have the certain epidemiological clues and the laboratory features and the compatible symptoms suggestive of this scrub typhus, you can straight away consider the diagnosis of scrub typhus and start the patient on empirical therapy. For example, in our patient had a history of this travel to the Coorg, where foresty areas he might have roamed, and he might have had an unknowing bite of the chigger mite. And again, he had a compatible symptoms. He had an eschar. He had the laboratory features suggestive of this scrub typhus, which is possible, like thrombocytopenia, the transaminitis, all these were possible. So the patient was actually put on the empirical therapy before the reports actually come. So the confirmation can be done by the 4 methods. So this is usually important in case of late period, or if the eschar is not there, then it becomes very, very difficult to diagnose the scrub typhus. Again, 40 to 50% of the patients, similar to erythema migrans, eschar may not be seen in case of scrub typhus. So the most commonly used test to diagnose the or to confirm the scrub typhus is the serology, that is the immunofluorescence test, immunofluorescence antibody test. Then the high single titer or the 4-fold rise compared to the previous titer is the diagnosis of this diagnostic of this scrub typhus. You can actually take the biopsy from the rash or the eschar, which usually suggests the lymphohistiocytic vasculitis is very typical of this scrub typhus involvement. And these are very tropical to the endothelial cells. So they infect the endothelial cells in the blood vessels. This is also again the entrance question. What is the site of infection of the scrub typhus? It is the endothelial cells of the cell line vessel lining. Again, you can take the blood culture where the growth becomes very cumbersome here, and it is rarely available in case of the laboratories. And PCR can be done in the early period, in the early infection when the antibodies are not developed yet. Yes, it is a definitive test where it can directly detect the genome of the concerned bacteria. The PCR can also be done from the eschar. This is also called as eschar PCR, if you can avoid the blood PCR in your patient. So there are 2 or 3 drugs available for the treatment of the scrub typhus. The one is the doxycycline, similar to the Lyme's disease. Again, this is a drug of choice. The 100 mg BD is given for 3 to 7 days is more than sufficient. Even sometimes a very high single dose, like 400 mg of single dose of doxycycline have also been tried. The 200 mg daily dose for 3 days or 2 days is also being tried. All these were succeeded with the right treatment. Whereas still now the Infectious Disease Society and the ICMR suggest the 100 mg BD, oral or IV, for 3 to 7 days. Again, as doxycycline should be avoided in pregnancy and ATS, the other drugs that can be considered are the azithromycin. In the doxycycline resistant case, this might work out very well. The dose is 500 mg per day or the 10 mg per kg per day. Again, azithromycin, again, I'm repeating here, it is given as a single daily dose. It is not given as a daily divided doses. It can be preferred in patients with less than 8 years in pregnancy, again, avoid in the patient of QT prolongation. Then pyramfenicol was actually the first drug which was to be effective against the this rickettsial infection or the scrub typhus. It was given as the 250 mg OD or 250 mg 500 mg every 6 hourly in the patient till the treatment is achieved. Chloramphenicol is also a good drug, but the side effect profile shifts the drug of choice towards the doxycycline here. So this particular chart is very, very important before the exam. The one question is definitely going to come with this chart. So the organism causing epidemic typhus, organism causing endemic typhus, organism causing the Rocky Mountain spotted fever, the vectors, all these are very, very important here. So one rickettsial infection which does not have a vector, please remember it is a Q fever caused by the Coxiella burnetii. So that whenever you try to revise the rickettsial infection, the first thing to remember is which is the airborne rickettsial infection, that is the Q fever. I think it has been asked many times in the entrance exam. Then you should know what are the louse transmitted, what are the tick transmitted, or what are the mite transmitted. We know that the louse transmitted are the epidemic typhus and the trench fever. The epidemic typhus is caused by the Rickettsia prowazekii. The epidemic typhus is also called as Brill-Zinsser disease. Again, these are fact-based questions. You should know these questions because the direct questions are going to appear in the NEET. The Brill-Zinsser disease is caused by, or the Rickettsia prowazekii causes which rickettsial fever. So all these are very, very common. Again, the rickettsial pox is caused by Rickettsia acari, is I think many a times asked question. And again, Indian tick typhus, since India is there in the name, you need to remember this is caused by Rickettsia conuri, and it is caused by the tick bite. So this slide is been available in all textbooks, and you should revise this textbook, this table before going into the exam. So to go for the case 3 here, the 32-year-old male construction worker referred from the family doctor. He complained, he presented to the family doctor with the loose stools, watery, and 5 to 6 episodes 4 to 5 days back. And his episodes were reduced now. Now he has developed the vomiting since 2 to 3 days and malaise. And he now has developed reduced urine output, which was high colored since 2 to 3 days. So he has developed the vomiting and the reduced urine output with the high colored urine following the acute diarrheal illness. So the patient does not have any significant past or the drug history, and patient again has received the same treatment from the same doctor with the ofloxacin with ornidazole combination and the loperamide as an anti-motility drug to reduce the episodes of loose stools, ondansetron and the ORS. So since the patient was not relieved, he was referred to the hospital. On arrival, he had the tachycardia of 112. His BP was 140/86, that is a little bit higher. His respiratory rate was 24. His temperature is okay. He had a saturation of 98%. So on examination, he had pallor. He did not have any icterus or the edema. The maculopapular rashes were present over the back and the abdomen. And the scattered petechial rashes were present over the neck, preferably, and the rest of the systemic examination was normal. So this patient, so these pictures were actually taken from my OPD. So if you see the petechial rashes were distributed over the neck, and if you can see some petechial rashes here also, and they were actually the maculopapular rashes, which are not actually visible properly in this. He had a maculopapular rash, and he also had these petechial typical rashes on the back, and this was his urine sample. So he had a high colored urine in the presentation. So the laboratory tests were done. He had an anemia of 8.4. He had a leukocytosis of 12,000. He had a thrombocytopenia. His blood urea was 65 and his creatinine was 1.9. It was increased. Total bilirubin and now direct bilirubin is normal. The OTPT was slightly raised. His alkaline phosphatase was normal. His CRP was raised. His ESR was raised, and his LDH was very high. So the peripheral smear was done, and the background of anemia, he had an anocytosis and poikilocytosis. WBCs were increased, and platelets are reduced in number. Again, no atypical cells were there. I think very difficult to get peripheral smear in the low-income settings because many a times the peripheral smear is being sent very late with the pathologist, and the pathologists are usually not keen, and they are not ready to see for the expecting abnormalities. They're not ready to discuss even after informing specifically to look for the schistocytes in this patient. The peripheral smear sample was actually negative because in the background of anemia, I had specifically asked the pathologist to look for the schistocytes or the elliptocytes or the abnormal cells, but the report came as no atypical cells. Again, the patient's the coagulation profile was done. The PT was normal, the PTT was normal, the INR was also normal because the DIC was the differential diagnosis in my part. And again, D-dimer also came as normal since this ruled out DIC. And urine examination was conducted. It revealed mild proteinuria and the hematuria was present. The proteinuria was present and hematuria present. So as soon as the hematuria, if you see, again, it is important to remember if this hematuria is the glomerular origin or if it is coming from the area which is below glomerulus. So how to differentiate this? You need to send for the urine active sediments. So this urine active sediments came positive for the dysmorphic RBCs. If you see the dysmorphic RBCs, then it is a true sign of the RBCs coming from the glomerulus. That means there is a glomerulonephritis. This is a very, very important thing you should remember. Here I'm also focusing on how to actually go ahead with the management or go ahead with the evaluation of these patients in the management. So once we encountered the acute kidney injury, the next very important thing is to see the urine. The urine had hematuria, which might be possible with the urinary stone. It can possible with the trauma. It can possible with anything. UTIs can possible. So to know whether these RBCs are coming from the glomerulus or it is coming from the area which is below glomerulus, we need to see for the urine for the dysmorphic RBCs. And here the glomerulonephritis was suggestive because of the dysmorphic RBCs. Another evidence of the glomerulonephritis is the RBC cast. So if you see a RBC cast or the dysmorphic RBCs, then it is suggestive of the glomerulonephritis. So since in the background of the anemia, thrombocytopenia, and there was an acute kidney injury that was due to glomerulonephritis, so then to look for the cause of anemia in an adult patient who is otherwise healthy, so we had to rule out the hemolysis in this patient. So to rule out, we got the hemolytic profile. The corrected retic count came as very high, that is more than 20%. The serum haptoglobin was actually undetectable. This proves that patient has the hemolysis going on. So again, the LDH was very high. The repeat LDH was also very high in our patient. So to know whether this hemolysis is immune mediated or non-immune mediated, we got an Coombs test done. Then it was suggestive of the non-immune mediated hemolysis. So in our patient had a hemolytic anemia that is non-immune, and thrombocytopenia and acute kidney injury, followed by a history of diarrheal illness. So actually the thrombotic microangiopathy was my first possibility in this patient. But one very disappointment here was the atypical cells were not seen. If I had seen a definite, or if the pathologist had seen a schistocytes, then no other diagnosis, no other investigation would have required in our patient. But we went ahead with the possibility of this thrombotic microangiopathy in our patient with the background of acute kidney injury, followed by a history of diarrheal illness. We know this thrombotic microangiopathy can present as the hemolytic uremic syndrome or the thrombotic thrombocytopenic purpura. Although this HUS, we have read, this is very common in children's, whereas in adults, the TTP is very common. In HUS, we see that hemolytic anemia with RBC fragmentation, although in our patient, he had hemolytic anemia, but he did not have any evidence of RBC fragmentation. Acute renal failure was seen along with the glomerulonephritis, and thrombocytopenia was seen. CNS symptoms were not there in our patient. Then the hemolytic anemia, renal dysfunction, thrombocytopenia, plus the severe CNS symptoms and fever actually goes in favor of the thrombocytopenic TTP. Whereas the mild CNS symptoms are absence of fever. Remember, when the patient develops HUS after the infection, he does not have any fever. Whereas in case of TTP, the fever is persisting in the patient. So the patient did not have any fever, but the age was against the HUS in our patient. So again, to rule out the TTP, we initially got done the ADAMTS 13 antigen concentration. This came out as 1024 nanogram per ml. So normal values from 750 to 1100. So this came as normal. So the TTP was not possible in this patient. So again, I had told the duty doctor to send the stool sample for the E. coli and the Shigella. The stool culture came positive for the Shigella dysentery. So this patient was actually having an hemolytic uremic syndrome by the Shigella dysentery. Again, I had ordered for this specific strain of 157 and H7, but the laboratory which I had sent did not have any particular growth media to develop this particular organism. To grow O157 H7, which is a very common serological subtype, which has been implicated in the E. coli in causing HUS. So this was not possible in our case, but this grown Shigella dysentery, I think this is a convincing evidence to call this as the HUS caused by the Shigella dysentery. So again, we know that the acquired hemolytic uremic syndrome can occur in infections and non-infections related conditions. So this acquired infection related can occur in many organisms. It can occur in E. coli and it can occur in Shigella dysentery. The many newer strains of E. coli has come in the causing HUS, although the very historically famous one was the O157 and H7. In India, I think there is 20 to 30% of this particular strain which is being presently circulating. Then the streptococcal pneumonia can also cause this the HUS syndrome. Again, the HUS caused by streptococcal pneumonia can be very severe. The renal dysfunction can be severe, where patient might progress to CKD sometimes. And here it can be occur by the streptococcal pneumonia causing bacterial pneumonia or the meningitis. So they can have the streptococcal pneumonia caused HUS. So this bacterial pneumonia in the background of the rise, what you call creatinine and thrombocytopenia with the hemolytic anemia should be suspected as the streptococcal pneumonia, because in many of the entrance coaching classes, they have been taught that hemolysis is a feature of mycoplasma infection. It is not only a feature of mycoplasma infection, it is even possible in case of streptococcal pneumonia if it is progressing into the hemolytic uremic syndrome. Again, it has been very common, TMA has been very common in HIV also. The H1 influenza is also been reported to cause the HUS. Entamoeba histolytica and mycoplasma pneumonia are rare organisms. The case reports in the history in causing the hemolytic uremic syndrome. So if you see the non-infected causes of this hemolytic uremic syndrome, the antibodies, the complement factor is very common, especially in case of the autoimmune conditions like SLE, the APLA. Then medications are very, very important in causing the acquired HUS syndrome. Among that, the most notorious are the calcineurin inhibitors, tacrolimus and cyclosporin, whenever they are used after the solid organ transplantation, especially in the initial period where the dose of these drugs are very high. So this can cause the HUS. Then cytotoxic drugs used in cancer, especially in children, that is mitomycin, bleomycin, gemcitabine, and cisplatin can also be regarded. The newer drugs like anti-VEGF, the vascular endothelial growth factor antibodies, so which are basically used to prevent the angiogenesis, especially in case of diabetic retinopathy and all these things. So are also been implicated in HUS syndrome. Others like the quinine, the anti-malarial drug, the interferon beta, although rarely used now, the oral contraceptive pills have been implicated in causing the HUS syndrome. So the other conditions like the autoimmune conditions like SLE and APLA can have, and the pregnancy can also have the TMA. So this is one of the differential diagnoses for HELLP syndrome in pregnancy. So this is how you usually goes for the diagnosis. So the management of the HUS caused by the post-infection period is just supportive. You just need to correct anemia, like maintain the hemoglobin between 8 to 9, consider blood transfusion when the hemoglobin is less than 7 or when the PCV is below 18. This is very, very important. And thrombocytopenia should be managed very promptly. Consider the platelet transfusion whenever there is a bleeding or whenever the patient platelet count goes below 10,000 without any bleeding. The fluid management is very, very important. This should be done with the CBP in line. The patient should not have an overload also, because in the background of AKI, patient can easily have the hypervolemia. Electrolyte management in the background of acute kidney injury. Acute kidney injury patient management is very, very important. Sometimes patient may need dialysis. The hypertension should be managed in this patient. So as I told you, in our patient also had 140/86 blood pressure, although we did not require any antihypertensive. The antihypertensives of choice are actually the calcium channel blockers here. It is the nifedipine and the nicardipine. Sometimes there is a discussion going on for the use of AC inhibitors. But since in the background of renal dysfunction, many of the physicians or the rheumatologists, they usually avoid using ACE inhibitors in the background of acute kidney injury in patient of HUS. Then this neurological dysfunction in case of the HUS. Although it is very rare in case of the HUS to have a neurological involvement, it is very, very common in case of the TTP. It can even occur in the HUS. Whenever there is a neurological involvement, you can consider the definitive management with eculizumab. We know that eculizumab is being used in case of the complement-mediated HUS. The post-infectious HUS is just managed by supportive. Whenever the patient is having a severe neurological involvement, the eculizumab can be considered for the management. I think I have used once the eculizumab in my entire 4 to 5 years of the internal medicine practice. The dose used was 900 mg. So there was one case of complement-mediated HUS in my PG time. So after that, we did not have any patient to use eculizumab in practice. But since it is being usually approved for the usage in case of complement-mediated HUS, the post-infectious HUS, especially the CNS involvement is being very, very peculiar or very not responding to the treatment, then you can consider the eculizumab as the management strategy. So the three cases which I took for the discussion today is not to tell about these particular infections. So this is actually to know how to go ahead with the management and how it is very important to have the diagnosis in the hand before going into the management. So this is very, very important. Please try to have a diagnosis just before putting the treatment for any patient. So in the next classes, we'll be discussing with the organ-specific infectious syndromes. So the GI system related infections and the central nervous system related infections we will take before going into the next system. So if any particular classes is to be taken by me on any particular interested subject, let me know through my WhatsApp or YouTube discussion, which I can go with the management. So there are some questions here put here is, can someone carry the bug from another country and spread it here, sir, like in his body and all? So if for example, if the patient has the Lyme's disease and he have the Borrelia in case of his body is circulating. So usually what these ticks, when they bite the humans, they usually don't suck the blood from the humans. The main reservoir of them is the what you call the mice, the deer, and all these things. And to spread from the mice to the tick has to be attached to the mice skin for at least for 48 hours. So it is not possible for humans to have a tick for continuously attached for the 48 hours. So it is not possible from blood in the human, the Borrelia in the human blood getting transferred from the human to the tick and again going into the other humans. It is very rare, because the time of attachment is very short in case of the humans. Then enteric fever without diarrhea possible, sir? Definitely possible. Enteric fever can occur even without any GI involvement also. Nowadays, it has been very, very common also. Like enteric encephalopathy has been a very drastically increased nowadays. Initially, we used to speak the complications of enteric fever, which usually appears in case of the 3rd week, are usually related to intestine, like rupture is possible, the obstruction is possible, the patient can have peritonitis due to rupture and all these things. But the incidence of these intestinal complications are drastically reduced nowadays. The main complication of enteric fever nowadays, which we have seen, is the enteric encephalopathy, which can even occur in the 2nd week of the enteric fever with the improper treatment. Because even if the patient is treated for enteric fever in the by the local practitioner, the dose of the drugs used is very, very low in case of the ceftriaxone and azithromycin is concerned. And people usually forget azithromycin in case of enteric fever, which is being the mainstay nowadays due to the growing resistance of the ceftriaxone, the extremely drug-resistant organism possible. And in the last 2019, there was an outbreak in the Pakistan, where the enteric fever outbreak actually killed many people. And here the organism was actually sensitive to only meropenem. All the drugs were actually resistant. The meropenem and azithromycin are the body drugs which were sensitive. And azithromycin is a very strong contender for the enteric fever, because enteric fever, the salmonella organisms, it's very difficult for them to develop this resistance to the azithromycin. So that's why azithromycin is a very important factor in the management of enteric fever nowadays. The dose is also 1 gram per day, followed by the 500 mg daily. So while dealing with the enteric fever, we'll take this particular discussion. And enteric fever is definitely possible without diarrhea. The constipation is also common in case of enteric fever. The diarrhea can also occur, and it can even occur without any GI involvement also.